Hi, this is Andrea Kane from HIT 340 Comparative Records. We are now stepping into dialysis and correctional facilities this week 5. So that is what we're going to be talking about. The first video I'm going to do for you is on dialysis. The second one will be correctional facilities. And these are two important settings that not a lot of people know about. But there are definitely employment opportunities in these areas. So let's talk about dialysis. This really focuses on patients that have end-stage renal disease. And it's going to talk about dialysis facilities, the fact that they are surveyed for compliance with various regulations and standards, and they do have some documentation requirements. I have worked for organizations who have had dialysis units. They have had dialysis units that were owned by the hospital and staffed by hospital people. And they have also had, I've worked for other organizations who have had outsourced dialysis facilities where they were outsourced to, say, a DaVita, where they came in and they provided the staffing. But the hospital was still responsible for them, making sure they were compliant and being a part of accreditation surveys. So there is that. If you are wondering how this relates to your syllabus, we're still technically under ambulatory care. So that would be 9.1.1 through 9.1.15 that we'll talk about this. Okay, so let's move on. We will talk about payment, how it gets paid, because end-stage renal disease is one of those that's picked up by Medicare. Regardless of the patient's age. And then there are end-stage renal disease networks. There are quality improvement activities that are specifically geared for end-stage renal disease. And then we'll talk about how HIM people are involved with organizations who have ESRD. It's easier for me to say end-stage renal disease just because that's the way I sort of grew up with it, so to speak. So what is dialysis actually? It is a procedure that maintains the life of a person whose kidneys have failed. This means their kidneys cannot function. The function is so very low, they cannot do any of the functions that they are typically supposed to do, which when you think about it, goes back to the filtration of the blood, pulling out the urea, waste, salts, the hormones that need to be broken down, all of those things, pulling those out, then putting back in the water, pulling that out, then putting back a little bit of the water, a little bit of the salt, a little bit of the sugar, and making sure that they take in and filter out medications and other types of waste so that it allows the body to create urine, purify the blood, clean it up so that it can go back through and be oxygenated. So that's really what it is. You've got a person whose kidneys have failed. They cannot function on their own. They cannot perform as they need to keep the person alive. So they have to have dialysis, and they have to have it several times a week. This is not a once a week type thing. This is truly someone who has to have this on a routine basis to keep them alive. Chronic kidney disease is a gradual loss of kidney function. There are 5 stages of it. Stage 5 is essentially end-stage renal disease, or end-stage renal disease. So you start with very mild loss, and then you get to severe total loss in those later stages. Oh, just mentioned that, stage 5. Sorry, talked ahead of myself. And so it is that stage 5. And at that point, either they're going to need dialysis on a regular basis or they're going to need a kidney transplant. Renal replacement therapy is a treatment that substitutes for kidney function. And so that's sort of an umbrella term, a relatively new umbrella term that is sort of like, okay, you need renal replacement therapy. It can either be dialysis or transplant. And as we know, transplant takes a while. It's not something that you sign up for today and show up for next week. You have to wait. You have to go through the National Registry. You have to be matched. There has to be a donor. You know, all of these things have to happen before a transplant can take place. So people with end-stage renal disease end up on dialysis almost always, even if they're going to be in a transplant situation down the road. So where do they get this treatment? They can have it in outpatient facilities. And as I talked about a little bit earlier, they can be hospital-based, and they can be hospital-based and staffed and owned and everything hospital-based, or they can be hospital-based that has been outsourced to a dialysis service or a dialysis company that provides the services in that space, or it can be a freestanding ambulatory center that provides dialysis treatment. There are all those options. They may be called a limited care unit, a dialysis facility, a dialysis unit, dialysis center. Those are some of the synonyms you might hear for it. ESRD networks do not directly treat patients, but they process and analyze data and provide other types of services. One thing about these patients is because they're getting these treatments, and these treatments are very expensive and ongoing, is that a lot of documentation is required regarding these patients, and it has to be submitted. It's looked at very carefully. So this is an area of high scrutiny. What is the definition of a dialysis facility? It is an entity that provides there's three things: outpatient maintenance dialysis service, or home dialysis training and support services, or both. And as I said, they can be independent or hospital-based, or a self-care unit that allows someone to come in and actually do it themselves. They basically provide the equipment and the supplies, and someone comes in and can't even speak it, sorry. They do their own dialysis by themselves, unsupervised, which again is somewhat dangerous. I'm sure they have people there that are overseeing that, but there's not someone who's actually doing this for the patient. And that's the difference between a self-dialysis service and an independent or hospital-based type situation. So, end-stage renal disease. They have stage 5 CKD. They're doing what's called hemodialysis or peritoneal dialysis. Let's talk about hemodialysis, because that is typically the go-to. When we're talking about dialysis, almost always you're talking about hemodialysis. That's the blood circulating extracorporeally through the artificial kidney. And it's performed 3 times a week. Sometimes more. If you have somebody who's super sick and for whatever reason they need it more, sometimes it can be more, but it is almost never less, because that is how often it has to be done to maintain the health of someone whose kidneys have failed, completely failed. So just keep that in mind. If we use the word dialysis, or if you're in a hospital setting and you hear the word dialysis, they're talking hemodialysis, and they're just talking about the blood. If you hear peritoneal dialysis, that's different. That is where you're using the abdominal cavity to filter out the waste. And there is something called continuous ambulatory peritoneal dialysis that you, as a person, if that's what the condition you have, you can come in and you can do this 3 to 4 times per day. Notice the difference. It is per day, and it is peritoneal. The next option is continuous cycling peritoneal dialysis, and you do that once a day, but while you're sleeping. And again, both of those, the CAPD and CCPD, are done with the abdominal cavity, peritoneal dialysis. Very different than hemodialysis. So what are some caregivers that are involved in this? We kind of talked a little bit about this. Typically, it's registered nurses. Sometimes you have LPNs, sometimes you have certified dialysis technicians, but typically it's registered nurses, at least in the hospital-based setting. In dialysis centers, you may only have a handful of registered nurses, and you may have certified dialysis techs that help and are doing more of the hands-on work, leaving the nurses free to do some of the more complex treatments. And then, of course, you have to have physicians involved. Physician has to give the order for the treatment, has to do the documentation justifying the treatment, and whoever provides the treatment, whether it's an RN or certified dialysis tech, absolutely has to document. Dietitians are often involved because these are individuals whose nutritional health is of utmost concern. And then also social workers. Typically, these are people who cannot work or who are elderly, older, and may have other complications, comorbidities, types of situations where this is not the only problem that they're dealing with. So you need, in a successful program, to have the dietitians and social workers be working with the patients in addition to regular physician evaluations, and then the people that you interact with when you're actually getting the dialysis. And then, of course, if it's a transplantation situation, it's visiting with that surgeon. And those are usually at major medical centers only. Kidney transplants aren't usually done at your local community hospital for a number of reasons, a number of good reasons. All right, so regulatory issues with dialysis. There are definitely lots and lots and lots of federal guidelines. So if you show interest, decide that this is a field you want to go into, and you contact your local dialysis center or your local hospital, and they have an opening for HIM related to that, make sure you go and spend some time with federal guidelines, taking a look at those and making sure that you know how they govern this, because they are a highly regulated area. There are different types of surveys. There's absolutely state surveys, depending on the state and how frequent they are and what kind of documentation they require. There are validation surveys, sometimes by federal surveyors. And then, of course, there's accreditation if it's a hospital-based dialysis facility. And there are also ways to become accredited even if it's not hospital-based, if they so choose, because there are other accrediting agencies. So let's talk about that dialysis unit in a hospital. It'll be accredited by Joint Commission or another organization such as NIAHO. Accredited hospitals have to meet the standards and conditions for coverage, conditions for participation, those types of things. And believe me, I have been through enough Joint Commission surveys in my career to tell you, if you have a dialysis unit, the surveyor will go there. You can pretty much guarantee it. They'll make at least one visit to that dialysis clinic, and they will go through it with a fine-tooth comb, because dialysis is just such a hot spot in healthcare. Whether you're talking accreditation, regulation, documentation, certification, cleanliness, anything like that. It's all right there. So just be aware of that. It's an important place to make sure that you're checking on the documentation on a regular basis to make sure it's complete, it's timely, it is accurate, it reflects the care provided to the patient, it's specific. All of those things, you want to know that that is happening. And then you hope that somebody from quality management or another area is looking to see, are they following hand washing? Are they using PPE appropriately? Are they going by the National Patient Safety Goals and making sure of the ID of the patient, 2 patient identifiers, all those types of things. And many are surveyed almost always unannounced to make sure that they're compliant with those regulations. And again, the goal of the survey, identify lower performing dialysis facilities and either get them back to being higher performing dialysis facilities or to shut them down. And CMS sometimes conducts unannounced validation surveys to make sure that the state or the accreditation organization is doing a good job. Oh, probably 5 years ago, maybe now, there was a big deal in the accreditation world because the government started to say, we don't think organizations like the Joint Commission are doing a good enough job of following our regulations and making sure our regulations are being met for deemed status. And so the government got involved and they mandated that there were teams that had to perform validation surveys. And they claimed that they only did validation surveys on 5% of organizations, and that may be true. I don't know. I know that I have been through 3 or 4 validation surveys over 20 some years, so I guess that's probably about right. And what they usually do is they send in someone from the state to follow through and make sure that Joint Commission or the accrediting body did a good job, and they essentially put the organization through another accreditation survey, unannounced accreditation survey. If the state is the one who did the initial survey, then they will find someone else. Usually in the federal government, they'll have a team that will come in and do it. Either way, it's back-to-back surveys, usually within a 2-month period, and they're very tough, and they go right down the line with the regs. And so it's a good idea to just periodically, every couple of months, be checking to make sure that your dialysis unit is following all the regs. And that's part of corporate compliance as well. So where can you find these regs in conditions of participation? They are here. You can go to the federal regs and put in ESRD, federal regulations. You can Google it, and that will give that to you. And then ESRD Networks has quite a bit of information as well. Documentation, oh my. Because you're seeing a patient 3 times a week, you can get a lot of documentation coming from that. Most dialysis clinics are now electronic documentation, but back in the day, those patients had multiple charts that were 2 to 3 inches thick because of how often they were coming in and how they were there for an extended period of time. So you had multiple pages of documentation for each encounter. Also, you have an interdisciplinary team, hopefully, taking care of the patient. And so you have documentation from each of these individuals working on the patient and working on the patient's situation that need to be included. One of those is patient assessment. That's very important. You have to have patient assessment. There's initially a very comprehensive assessment that you have to have within 30 days or within 13 outpatient dialysis sessions. There also has to be a follow-up assessment within 90 days. You're looking at the patient and their baseline, then you're assessing the adequacy of the dialysis. Because on a monthly basis for those dialysis patients, you've got to be going and saying, can we see any improvement in this person? Is the dialysis working? They haven't worsened, those types of things. And then peritoneal dialysis, it's every 4 months. The patient assessment has 13 required areas that have to be evaluated. So some terms to know is obviously adequacy of dialysis, KT over V, and urea reduction ratio. The reassessment needs to be at least annually for stable patients, at least monthly for unstable patients, including patients that have extended or frequent hospitalizations, marked deterioration in their health status, a significant change in their psychosocial needs, or concurrent poor nutritional status, unmanaged anemia, and inadequate dialysis. So if a patient meets any of these criteria, they have to be reassessed monthly, not annually. And this is on top of the visit, the encounter, episode of care documentation. Additional terms to know: renal bone disease, erythropoiesis stimulating agent, ESA. A lot of these patients really struggle with anemia, and they may be prescribed erythropoietin, which, well, it's a stimulant. They'll be prescribed the stimulating agent, ESA. And what that does is it stimulates the hormone erythropoietin to make more red blood cells in the bone marrow. And then vascular access monitoring. Most of these people have a vascular port for the dialysis. And so it's monitoring that port to make sure it's not infected, that it's not clogged, that the port itself is changed out when it needs to be, those types of things. There has to be a plan of care. Obviously, there has to be a plan of care. It has to, you can't just say we're going to do dialysis. Well, what is the plan of care? What all is wrong with a patient or needs to be addressed, and how is it going to be addressed? There are at least 8 required areas. It needs to be specific about the services that will be utilized that are necessary based on documentation of the diagnoses of the patient, not just signs, symptoms, and test results, but diagnoses. It has to be signed by the team members and implemented within that 30-day or 13 outpatient dialysis session window time frame. It needs to be updated within 15 days of additional assessments. So let's say you have a patient who's going along and they're doing pretty well, and then they have some of those problems that we talked about a couple of slides back. And so now you are assessing them every 30 days. Well, every time you reassess them, you're going to have to update your plan of care within the next 15 days. And this is where a lot of places can get tripped up. You've got to know these deadlines, and you've got to stay between them. Now, with electronic documentation, theoretically, you can set up sort of a situation where, okay, anytime you redo an assessment within the next 14 days, it puts an alarm on. You've got to also do an update to the plan of care. But we all know it's really easy to click through those reminders on the computer. If you ever have one that reminds you, oh, you've got some new features, you want to take a tour. Well, we all click maybe tomorrow, remind me tomorrow, or remind me next week, or remind me whatever. We all do it. It's just that in this kind of setting, it can be really bad if you click through it. And then what happens if the goals are not met? Let's say that the patient, you've got this wonderful plan of care, you're implementing it, but the patient's not improving, or you're not seeing what you thought you would see, or they've had something else come up. You need to adjust that plan of care. And the sooner the better. You don't want it to go on too long. 30 days is usually what they give you, but you might want to stick closer to the 15. Other documentation issues are the monthly progress notes. You have to have somebody who's in a position of authority, who's looking at the patient on a monthly basis saying, yes, they still need services. Do we need to make any changes to the care plan? Do we, all this has to take place by whoever is authorizing treatment. Transplantation referral tracking. If a patient is strong enough, healthy enough for transplantation referral, then that needs to be managed, that tracking, that communication with a major medical center. Where are they at on the list? Is there anything that needs to be done to prepare them for an upcoming transplant? All of that. Patient education and training, that needs to happen. Ongoing. Patients need to be reminded about diet and their own care, and if they've got special needs, or if they have social needs, if there's something at home that is inhibiting them from getting to their appointment, or anything. You need to make sure your patient is involved and whenever necessary, educated or trained. Then the ESRD network has a forum that has developed a medical record model, and that has suggestions for good documentation. It's a good idea to go out there if this is an area of interest for you and really know what they require for dialysis documentation or what they recommend. And if they recommend it, it's well worth following, because then you can go back when you're being surveyed and say, here, we follow this national standard or this national recommendation. It just gives a better reputation and more of a positive weight on what it is that you're doing. So reimbursement, how does this go down? Well, as I said, ESRD patients are often covered under Medicare. One of these needs to be met. They need to have worked the required amount of time under Social Security, Railroad Retirement Board, or as a government employee. If they are eligible for or are already receiving Social Security or Railroad Retirement benefits, they are definitely eligible for Medicare coverage. And if they are the spouse or dependent child of a person who has worked the required amount of time to be eligible for Medicare, or who is getting Social Security or Railroad Retirement benefits, they also are eligible. So typically you will find with end-stage renal disease patients, almost all of them are Medicare coverage, so you'll be reimbursed based on Medicare. And Medicare has benefits for most dialysis patients. Their diagnosis can make them eligible for Medicare in the 3rd month after treatment begins. They can be the secondary payer during the first 30 months, with Part A paying facility and Part B paying the physician. Patients may also have other health plan coverage. They may. It depends on the market, and it depends on the patient's age and their background. Some patients' insurance will actually cover this. Other patients may be encouraged by their insurance carrier to pursue Medicare as a primary. It just really depends on the patient's situation. Other health plan coverage can be very expensive for end-stage renal disease patients, so that's another reason why they may end up perhaps being a Medicaid first, Medicare secondary, that type of situation. There is a prospective payment system for dialysis services that bundles or combines the services into a single base rate. There is a patient-specific case mix adjustment of the base rate, and that just goes on to give you the details of that. And of course, Pay for Performance has visited ESRD. There is a quality incentive program for that can reduce payment to the facility if they're not meeting clinical performance and reporting standards. And this is where it really impacts HIT professionals, is not meeting those clinical performance or not knowing what those clinical performance standards are, and or not reporting timely. I have worked in an organization where they were very siloed in their approach to this type of situation, and they had a dialysis unit, and what they did was they chose to have no one from HIM overseeing to make sure and checking that this was happening, and some reporting got missed. They lost some reimbursement for a significant period of time, and it was pretty impressive money, close to $100,000, and it's because no one was watching to keep up on what are the clinical performance standards under ESRD Quality Incentive Program, and are we collecting those, and then are we reporting those, and are we reporting them timely. Coding and classification, obviously we're using ICD-10 CM for diagnoses. We're typically using CPT HCPCS for procedures, because remember, this is an outpatient setting. So it'll be CPT HCPCS for both the facility side of procedures as well as the physician service and procedure side. Data and information flow, you've got individual patient data, you've got aggregate data, and you've got to make sure that you're getting it where it needs to go. You're collecting it so that you can be monitoring that. There's I don't want to say a data warehouse, but there's sort of a middleman called, well, let me back up. If you have a dialysis unit, you're pulling the individual data and it's being submitted electronically through CrownWeb, which is an IT solution. Then CrownWeb sends that data to ESRD, and they act as a middleman. They process the data, and then they transmit it to CMS. So CrownWeb is sort of the link between your IT system and ESRD. ESRD network gets the information through CrownWeb, and then they work their magic, so to speak, and they transmit it to CMS. Dialysis facilities, as I said, are pretty much electronic these days. They moved very quickly, especially those that were freestanding ambulatory facilities. Hospital dialysis units were not quite as aggressive in their approach to adopting EHRs, but now pretty much everyone has EHRs, whether you're hospital-based or you're ambulatory-based or you're freestanding-based. It's all, or whether you're a contract service, it's all EHRs. And so this just gives you an idea of different things that a dialysis EHR can do. And this is where the question and the argument comes up with hospital-based dialysis units. Do they use the same IT system, the same EHR as the rest of the hospital, or do they get a specific dialysis EHR that plugs in and interfaces with the hospital EHR system? Because there are so many benefits to using an EHR that was developed specifically for dialysis. You know, you think about the interfaces with the dialysis equipment, you think about how it's already programmed for those regulations. And this is where it can be helpful that if you have a dialysis program that is struggling with documentation, maybe it's because of the EHR that it's using, and some investigation needs to be looked into. What is the cost of a dialysis EHR? How would it interface with the hospital's EHR and the value for that? Because sometimes getting the appropriate EHR is better than using the hospital-wide one to ensure all is well, shall we say. Data sets. We are talking more and more about data sets. And I would encourage you to go out and Google healthcare data sets so that you're familiar with those. And obviously there are some here. And then the CrownWeb reporting system has those built in. And then you can go and get transplant data through the United Network for Organ Sharing, UNOS. What about quality improvement and utilization management? Because that's important in our world too. Well, there are goals for self-care and transplantation. Medically appropriate settings compatible with rehab has to be checked. We have to make sure that quality appropriateness of patient care is being set and measured and improved. And then when do you move patients for placement in treatment modalities? How do you know when it's time to change things for patients? Dealing with patient grievances. Maybe a patient is upset, or maybe something happened that was just a disappointment that needs to be dealt with, or heaven forbid a medical misstep, shall we say. Those all have to be dealt with, and typically quality improvement utilization management is involved. They usually like to see a council that includes a patient representative or a medical review board for dialysis units. And then, of course, there need to be on-site reviews as necessary, preparing for those unannounced surveys, because every day could be an unannounced survey. And really, shouldn't we be treating every patient, every encounter the same way, as if the accrediting body were in the building? If we really care about our patients, why wouldn't we do that? Why wouldn't we give them the best possible care, every patient, every time, by following the rules? So that's my challenge to people who like to prepare for surveys, 6 to 9 months to 12 months before they're expecting a survey. No. It needs to be everyday readiness. It needs to be doing the right thing for each patient every time, whether you have a surveyor standing behind you or not. And then collecting, validating, and analyzing data. That's all part of quality improvement, utilization management. The facility's QAPI, Quality Assessment and Performance Improvement Program, must address adequacy of dialysis, patient's nutritional status, mineral metabolism and renal bone disease, anemia management, vascular access, medical injuries and medical errors, the dialyzer reuse program. If that equipment is allowed to be reused, you've got to have some things in place and some monitoring and that sort of thing going on. Patient satisfaction and grievances, and infection control. Infection control is big. That is one of the first things they will look at with the dialysis unit. And I have worked in a hospital that got burned that way. They had outsourced their dialysis to a company, and we came in with a surveyor, and the first thing the surveyor saw was the nurse that was providing the care was not following infection prevention procedures. She wasn't washing her hands. She wasn't washing her hands between patients. She wasn't gloving or foaming in, foaming out, or gelling in, gelling out. She wasn't gloving properly. There were just several infection control things that they noticed and cited right away. So infection control is huge. And when you think about these patients, they are very compromised. They're relying on an outside machine to filter their blood. And when you think about their actual condition and all that can happen from that, they probably struggle with some immunity issues. And so it's really important for dialysis staff to follow infection prevention processes every single time to help keep these patients healthy and keep them from getting an infection. There is a quality incentives program, of course. Provider payment rates are affected by the performance-based measures, and this gives you some of those. Providers not meeting performance standards will experience a payment reduction up to 2%. And that's what I was talking about with the hospital-based program that lost the money for failure to make sure they were collecting all the data elements that they should have been. They didn't report them on time. And in one case, for one period of time, they didn't report them at all. They had that 2% reduction, which for them was quite a bit of money. So clinical performance measures and other projects. Again, go out to that ESRD Networks website, take a look at those. They're sort of, I don't want to say they're an arm of the government, but they do a lot of work for the government on this topic. And they have quality programs always going on. Utilization management, we touched on this a few slides before, but every patient must be assessed. Are they suitable for a transplant? Many are not, but they need to be at least screened to see if they could be, and if they need that referral to a transplant surgeon for further evaluation. Patients who have kidney transplants generally have higher survival rates, a better quality of life, and lower overall medical costs than patients on dialysis. So there are a lot of reasons why transplantation is good and something to be pursued. I mean, think about the patient themselves. Who wants to come into the hospital or into a dialysis clinic 3 times a week for the rest of their life? whereas maybe they could have a major surgery, and yes, they would have to take some immunosuppressive medications, but then they wouldn't have to have the dialysis. So it's really important that it not be ruled out until it's absolutely impossible or close to that. And then there are also ESRD network data that people use to study utilization patterns to make sure that patients are being referred appropriately, that those who aren't are getting what they need, and that their health is either stable or improving. So risk management and legal issues related to dialysis, well, there's general issues: consent for treatment, authorization for release of information, think HIPAA, confidentiality, security of information, all of that. There's also retention of the information. It needs to be 6 years from discharge, transfer, or death according to federal requirements. But remember, you have to go with the most stringent, and many states have more stringent requirements on retention of clinical information than this. So don't just go by the federal guidelines. Make sure that you look up what your individual state requirements are, as well as your organizational policy, because your organizational policy may even be more strict than the state. Documentation of patient education. You got to make sure that the documentation happened. If documentation didn't happen, then whatever someone says happened didn't happen. It has to be documented. And we have to be able to show that we are trying to make sure patients understand all aspects of their disease and their treatment. We need to document non-compliance. This is becoming a bigger and bigger thing in healthcare. If you have a non-compliant patient, you have a patient who skips dialysis appointments, or you have a patient who refuses to take their meds, you need to get to the bottom of it. Because first of all, you got to document it. Document the fact that they missed the appointment. Then you need to follow up and find out, and be careful about how you approach that. You need to approach it from a caring standpoint. Hey, we noticed you didn't make your appointment today. Are you okay? Because it very well may be that the patient wanted to come. Maybe the person that was supposed to give them a ride wasn't able to come, got sick, they didn't have a backup ride. Maybe they were feeling really ill today, and they're just feeling so bad they didn't even feel like picking up the phone to call and let us know. So you definitely want to document the fact that there's non-compliance. Another example might be that they come in for dialysis and they're talking about, I'm not going to take this medication, or I've stopped taking that medication. Oh, stop the horse there. We need to figure out why they're being non-compliant, but document it first. Patient stated XYZ. Why have you stopped taking this medicine? Is that something the doctor ordered? Because we weren't aware of that. And let the patient tell you what's going on. Don't be judgmental. Just make sure you document it, because that may be a way to identify a new patient need that you all need to work on together, or it may be a situation where you truly have a non-compliant patient that you need to go through the process of essentially letting go of, and then going through a process to say, as a patient, we can no longer provide you services because of your non-compliance. But that needs to be your last resort. And before you get there, let me tell you, you need plenty of very clear, concise, consistent documentation. Then, of course, there's the ethical issues. Dialysis is life-sustaining, and someone who is perfectly mentally, legally competent can say, I don't want dialysis treatment anymore. I mean, obviously, you'd want to have the conversation with them. Do you really understand what this means? Here are the risk benefit, just like you would for any procedure. If you don't have this procedure, what will happen? And that needs to be a conversation between the physician and the patient. But they have the right to say, I don't want dialysis anymore. I'm ready to die. I want to go into hospice, or I want to be home, or I want to go back to my skilled nursing facility. I'm done. And that's okay. They get to make that choice, but we just have to walk with them through that choice to make sure that they are competent, that they do know the risks that they're taking. And then we can be emotionally supportive. We can encourage hospice care. Hospice care also provides counseling and social work to the family, because it may be that the patient wants to stop dialysis treatment, but the family is against it. And when you get into situations like that, it can be a real sticky wicket. So just keep those kinds of things in mind. Definitely document. If you've got a patient that says, I don't want to do this anymore, you need to reach out to that physician immediately, because there needs to be a physician-patient conversation. And then from there, how does the dialysis program and its interdisciplinary team support the patient in whatever it is that they have decided? And same thing with transplantation issues. There may be someone who is very healthy but is frightened of a kidney transplant. And so they're pushing back against being sent on for a transplant surgeon appointment. Again, you need to work with the patient, but it needs to start with the physician to see what can be done and how you can encourage and support that patient through whatever it is that they're going through. You know, healthcare has become so much more than just the diagnosis and treatment. In the interests of healthcare, we need to remember the care, the genuine care for each individual. So HIM people, how can we be involved? Well, we may be an employee or a consultant for a dialysis service or for a unit. In the ESRD networks, they have medical record coordinators, data coordinators, quality managers, and executive directors. So there are plenty of opportunities in this field. It is a great field. It is definitely something that you can consider once you finish the program and have your certification. So in summary, I won't go through this because you can read it, and just talks about these. I say conditions for participation because that's what I was used to for forever, but it's conditions of coverage now, and I'll have to, conditions for coverage, I'll have to work on memorizing that. All right, and some more summary. Just again, might not hurt to go out and look at ESRD networks. If you're interested in IT solutions, look at CrownWeb. There's plenty of information out there about QIP for dialysis. And if you want to go out to the web again, Medicare.gov has lots of information. And that is all I have on Chapter 5, and it's a lot more than what I expected. I expected we'd just fly through that. Anyway, hope you're doing well. I will be back shortly with Chapter 6 on correctional facilities. Take care.